So our first session, yes, our first session was already recorded and uploaded to our YouTube channel. Wow. We're trying like a bunch of oldies trying to keep up with time. And so our first session with Buka Mulut was about photography in auto. And we had Dr. Waylun there, so you can check us out if you missed that session. So today is our second session, and we'll be talking about occlusal splits, right? So Dr. Ang Yee now is a lecturer. Actually, she's a resto specialist, graduated in UKM, and she's a lecturer in MASA right now. So yeah, we know that some of one or two of the student is here. Thank you for supporting your favorite lecturer. and she did share about occlusal spleen once before with Petaden, and now we will be talking about it again today. So anytime that you guys have any questions, do let us know. Type in the chat or anything like that. But if you're too shy, you can personally text me and I'll ask for you lah, okay? All right. I personally am not great, or not, I wouldn't even say I'm good at any occlusal spleens. So I'm here to know more about occlusal spleens as well. And don't laugh at me, okay? If I ask the big questions, yeah, it's all for learning. It's all for your sake.
And to know also when exactly I should give an occlusal spleen and what type of spleen, right, Karen? Because
Yep.
for us, a spleen is just use. Yeah.
Yeah. Okay. So let's start and let's begin with this. First question is, what is occlusal spleen?
Okay. Well, thank you so much. First of all, it's great to be able to do this because I think we all always have this kind of wish we want to do like some kind of podcast, because like how Jaren say, we can't stop talking. I mean, I've been talking also since I go to uni and talk until now, and then in clinics, and then still talking, still sharing. But I think it's fun lah. Basically, sharing and having people to know more what is the correct way of doing things is always what I think all of us want to be. And okay, so spleens. Basically, you can't have any other spleens like Barker spleen or what palatal spleen. It's just one type of occlusal spleen. The reason is because you wear it on the occlusal surface of your teeth, so you have to be an occlusal spleen. Then, why is it called a spleen? Because it's actually connected from one end to the other end. So I don't think so there's any better English to use. So it's definitely an occlusal spleen. And we usually prescribe it for patients who needs them. Then who are the patients that really need occlusal spleen? Actually, everyone can wear a spleen, no problem. Only in cases where you cannot wear a spleen. For example, patients who has TMJ issue that is always flexing, like it has a dislocated jaw all the time, then you might want to prevent. Okay, patients who is perio compromised, the teeth is already mobile, you can't fit in an occlusal spleen and then mobile together in the mouth, right? So that one also can't do. Okay, otherwise everything else, usually for me, all my full mouth rehab case, I would prescribe a spleen afterwards, regardless whether the patient has bruxism or parafunctional habit. If the patient has these two, then it's largely indicated you will need to prescribe a spleen. So for patients, even with veneers, with bridges, with implant prosthesis especially, you would want to put on a spleen for the patient. Understand? Can
The spleen is, do you have a picture? Okay, I mean, can I share my screen?
Yeah, sure.
Is this the spleen that you're talking about? This kind of thing? Is
No, this image, when you check occlusal spleen, over here got so many different type of
okay.
spleens right here. Okay.
Yeah.
So yeah, so most
Let's
of it,
select it.
yes, you can see the design of the spleen is not like an Essex where you cover all the way to the CEJ. So it's only halfway onto your anterior teeth and full onto your posterior teeth. And you see mostly is on the upper arch rather than a lower arch. So another name for an upper occlusal spleen is called as a Michigan spleen. Okay, if let's say you don't want your upper is all dentate, lower you have implant and all that, you want to protect the lower, you swap it around, you can prescribe a lower spleen. That will be known as a Tanner's spleen. So Michigan on the upper, Tanner's for the lower. Okay, so yeah, this is what exactly you will see when you Google it. So you can see on the left bottom one, there's a lower one, so that's a Tanner's spleen. Yeah,
one.
that's a Tanner's spleen. Otherwise, everything else is an occlusal spleen. So then there's modification to this spleen. For example, the one right on the left, second row in the middle. Yeah, that's an anterior, no, next to it. Yeah,
one.
okay, you see something at the front, right? So there's an anterior repositioning spleen. Okay, so this one is actually trying to manipulate the jaw to bite in a place that you want the jaw to bite. Okay, sometimes we don't know. The patient has got TMJ issue and you want to dislocate slightly and lengthen the muscle. You would want to increase this part slightly more so the patient get to bite backwards. So you call that an anterior repositioning spleen lah. Okay.
This one is like, this one is like, if let's say you have a full mouth rehab, then like they don't have a stable bite, then you have to use this one first, is it?
Yes, correct. You're right. So like talking about that, yes, you can issue the spleen before you start any case, or you can issue them after you do everything. So like the life care dental, that one confirm it's not a spleen, okay? That's false image. You shouldn't do that. That's actually just an
Where?
Essex. Yeah.
This one? Okay,
Yeah.
this is just an exit. Yeah, okay. Essex retainer. Looks like
Yeah,
an
lower
Essex
one also.
retainer.
Lower is an aligner. Come on lah, that one.
This is Google I just randomly put. Okay.
Yeah,
So
I
if
know.
you're saying
So
occlusal spleen, then it's
you need
always
to,
the upper lah. Pretty
yes.
much always the upper, which is
I
also
will
known
always
as
give an
Michigan
upper.
spleen, is it?
Correct. I always give an upper. I rarely give a lower unless the protection is for the lower.
What if you're doing upper and lower?
Then just choose upper.
Then okay, yeah.
Yeah.
Okay. Then like I see this one and see this one, or the outer surface here is just flat only. So technically, if it doesn't like don't have to even touch or need any indentation for this kind of teeth, is it? It can be just flat and then you just wear it on the upper and then that's it.
Yeah. It depends what sort of design you want. For example, like this one, in this case, I'm just guessing that they want to just do an increase in the vertical dimension so that they generate space in order to restore other teeth. Then yeah, you just prescribe a flat one. But in cases where the patient already done the rehab and you want the patient to have proper single point bite on each tooth, and then canine guided upon lateral excursion, then that one, yeah, you need to have some form of indentation. In fact, the indentation is very important. Later, I have a picture in my slides to show you where exactly the indentation is important.
And how to do it?
How to. Okay.
Thank you.
Yes, and how to. Okay.
Okay.
This one used to be conventional way, means after you've done the lab has done the acrylic spleen on a semi-adjustable articulator, then they will use articulating paper and they will open, close, get the point, trim like that. Okay. So that was a very olden day Michigan type of spleen. And nowadays, because we have 3D printer and 3D printer has its own resin for night guard, so all these things are already done in the software, okay, in the ExoCAD. So once you place in, they already generate the indentation. You just need to pick where you want your indentation to be and smoothen out the rest. Then they just print that.
Then okay, speaking about, you mentioned the resin, right? So what about the material wise? What kind of material? I mean, like the resin, right? Because you see sometimes some spleen or night spleen or something like that, or night guard. Is it the same thing? It's not the same thing, right?
Yeah, it's not. Actually, night guard is
Like
just a
night
guard
guard
that
is
you
like
wear
in,
at night.
and
Yeah,
then like
which I
there's
think
like
most of
one
us.
soft, one hard, one kind of thing.
Yeah, I think most of us, before I studied also, I thought night guard is just something like an S6 retainer that is extra spongy with 4 mm thickness, that kind of thing. And you can just easily cut it and use the same S6 retainer vacuum machine to do it. You just change the sheet itself. Yeah, I used to thought it was that, but actually no, if you're doing that now, maybe you should try not do that anymore, because evidence has said that if you're issuing a soft spleen, like a chewing type of spleen, like a gum, rubber, of course, it's very comfortable. A patient can fit it in very easily, but actually that aggravates and worsen the parafunctional habit. So if you issue that, although patient feels comfortable, but you're not doing any good. It's just very, that patient, because it's very rubbery, so the patient tend to even plucks even more. Okay, instead of trying to stop, you're actually just making it worse. So best not to. If you want to prescribe that, it can be something very temporary. For example, if you are in the process of rehabilitating a patient, and the patient is on a lot of composite, and you know eventually the patient will have to go for a Michigan spleen, then you want to protect the composite throughout the process, yeah, you can give something of this kind of soft material first. So it's a temporary splint, or basically just don't give, okay? Then you have the hard spleen. Hard spleen is basically what I give all the time, because I believe through the hard spleen, you can see the indentation of the occlusion, you can trim, you can polish. Okay, but hard spleen is a little bit tough in cases where patients have mild crowding, okay, or maybe even moderate crowding, or some cases where you have edentulous area. Okay, so then we will change it to bilaminar spleen. Bilaminar spleen is soft on the inside, it adapts to the teeth nicely, and then hard on the outside. Yeah, so I still can do my occlusal adjustment on the outside. Okay, it has no difference actually. Yeah, when you look at this and you look at any other hard spleen. So to choose either a hard spleen or a bilaminar spleen, you will depend on how much of rehab you have done for the patient. What are you going to prescribe for? Are you going to do it for TMJ issue and all that? And usually in cases that we have already rehab all, the occlusion is quite nice. So then it can be quite safe to just go for a hard spleen. In cases where patient you only rehab 1 or 2, and then other part are still natural teeth that it has crowding, you want a soft. Or in cases where patient wears denture, later I will show you some of my cases. The patient wears denture in the day, at night take out the denture, straight away collapse, right? Then you will be afraid like, oh, maybe your composite will chip off, because with the denture, the patient has even bite. Without the denture, then all the force will go to your anterior teeth, for example. Then you will want to prescribe a bilaminar spleen, soft on the inside where the patient can fit in nicely to the tissue, and then outside is still the hard spleen. Can get it?
Yeah, but then it's still soft. Oh.
It's not
What's the
that
difference between-
soft like a rubber type of soft. But it's not the
Okay.
really hard type lah, yeah.
So I mean, like the reason why you say those kind of soft little spleen is will cause the parafunctional habit to be worse is because it can sort of like got the pouncing,
Yeah,
got
yeah.
the rubbery feeling that patient can still
Yes.
bite and chew like that, right? So but this
Yeah,
one
correct.
even though it's like soft inside, but it's not that soft lah.
No, it's
Right.
soft inside, as in towards the teeth. When you wear it, it's soft. But when the bottom teeth is biting onto that, it's hard.
So there's like also indentation on this biominerals where when
Yeah,
you bite,
yeah.
it fixes
Correct,
the bite
correct.
there.
So the lower teeth will still feel hard on the spleen. But when you wear the spleen onto the upper teeth, that part is soft.
So that one is more. Can we classify that as a night guard? Not really, right? Can.
No, I mean, there's no night guard per se. It's just basically you wear something at night, they call it night guard lah. So everything is a night guard. Yeah, but
Yeah,
then we
that's
just
true.
prefer to call it a spleen, because that has a bit of a functional role in it rather than just protecting it at night. You still do a bit of an occlusal analysis and making sure that even the patient is sleeping, the occlusion is ideal. So we will try to call it as a spleen rather than a night guard. But it's the same, it's the same.
Okay. All right. I think we got that cleared up. Right. For me, that was at least Yeah. Okay. Then, uh, we were looking, and then suddenly got this that S6 retainer kind of thing, right? Why that
Mm.
cannot be classified as a splint? Because it's also holding from one end to another end.
It's too thin. The material is way too thin. Yeah, and it doesn't really protect so much because a splint comes with thickness. So later I'll have my criteria of splint. So as the splint comes with thickness and it will actually lift the jaw up. But an S6 retainer is so thin, I think it's 0.5 or 1 something, right? So it's so
1 to
thin that
1.5.
actually it doesn't really affect much of the occlusion. So when you wear on it, it's like as though you didn't wear anything. So there's no point. There's no exactly much of a protection in it. So in patient who bruxes a lot, if you prescribe S6 upper and lower, they will always come back and say break, break, and break, like especially at the posterior part.
Yeah.
So no, S6 retainer it retains the position, but it does not have much of a protection, and Lagi don't have any occlusion, functional occlusion onto it.
Yeah, because it's like plastic on plastic thingy,
Yeah.
right? There's no indentation, no biting like that. Okay. So now that we got that settled, do you want to go to talking about how do we make this occlusal splint? Or anything that we should cover before going to that?
I think quite clear already. Basically, you just have to know why you want to prescribe the spleen, when you want to prescribe the spleen, either before or after, and then how we want. Actually, spleen is quite easy for us as dentists. We just need to take an impression. Yeah, very easy. Take impression, and then take the bite. Okay, but the bite is the challenging part. So all of us should practice taking bite as a centric relation. Try to guide the patient's jaw backwards by manual manipulation. Ask the patient to swallow multiple times, put the tongue up, guide the jaw until the first point of the tooth touch. Okay, so usually that's what I do. Then that's your CR. Then you try to record that. Okay, so if you record the CR and you send that to the lab will raise the bite from there. And then from that, you will see that 2 millimeter of thickness, and they will just fill up the space with the acrylic splint. Yeah. So what I do is a bit shortcut. I don't do this anymore. I will give the lab the 2 mm from the mouth. So I just ask the patient to bite onto the back end of the, okay, sorry, this one is just my own tips, okay? The back end of my bonding agent. Yeah. The bonding agent applicate the tip.
Oh,
That thing is 2 mm also. So I just ask the patient to bite. Okay, got clear. Then after that, I just scan, and then I get that space that I want.
You put it on the
Yeah.
anterior here, right?
Yeah, correct. Then forward, backward, and then guide, and then go backward, and then just stay on that position, and then scan it both the left and right side. Then immediately your scan will get detect, and then you get that space. Then you send that to the lab. So the lab will know, oh, this is the space that you want your spleen to be. Yeah.
is
Then-
there
So okay.
is there like a instead of using the micro brush applicator, is there a more fixed way that you can use? There's a jig or something
Fixed
like that.
way. Yeah, but that's very tedious because you end up have to you have there's this thing called as Lucia jig where you use Durale, which is an acrylic, and then you shape them into a ball, adapt it to the anterior teeth, ask the patient to bite, and then get that point, move forward left and right, and then get that chaka ayam look. Yeah, that's one. But sometimes Durale is a bit hard to do. So what I do is I take expired composite and I will use the expired composite, roll into a small ball, adapt to one incisor, and do the same thing as well. Yeah, but I realized that if you get that jig, not all the lab knows how to mount.
Right.
And then nowadays, because we scan, right?
Yeah.
So after we scan, we can't give them that thing. Yeah, we can't give them that thing to verify. So end up also is the patient is biting something on the front, and then you're scanning it on the left and right side. and then the
Right.
lab will still take that. Yeah. So that's one way. There's many other things that is 2 millimeters. For example, your plastic instrument, if you lift it up, it's 2 mm. If you lift it down, it's 1.1 mm or 0.9 mm like that. So depending on how much space you want, you can ask the patient to bite on your plastic instrument and you see that space that you want to. Yeah, that's also another way. That one is usually my cikgu's way lah, that last time in UKM. Then another way is also you have to deprogram, which is very important. Not all patients are so easily guided. Okay, have you ever experienced patients that no matter how you want the patient to bite, just cannot? The patient just don't know how to bite,
Yeah.
right? You ask the patient to bite, lagi the patient don't know how to bite. Yeah,
Yep.
really. Yeah, and if you ask them to bite, they like to bite forward. They like to go
Yeah.
forward.
Every single
And you
time.
want them to, yeah. And you have to ask them to, and you ask them to bite backward, they don't know what is backward. It's just very, very tough to get. So you have to make the patient forget, like the muscle to forget how to bite. So you call it as deprogramming. So if you deprogram, then most of the time I would just ask the patient to bite cotton roll. Okay, just to lift it up forward and backward, and then for a good 2-3 minutes, sometimes even longer, 5 minutes, just at that position, and then ask them to open the mouth as wide as possible. At the moment the muscles forget, then you quickly guide to the CR. Yeah, but if you see Lesman, he very atasy one, they will have leaf gauge. So you use leaf gauge also can. You put in a chunk of leaf gauge and then you slowly take out one leaf until the one point touches, and then you can get that space. Also
Yeah,
can.
but
That's the
leaf gauge also
best
need to
way
train
actually.
more. Leaf gauge also need to train
Yeah.
one more.
Yeah. You also need to do the forward backward movement, yeah, with the leaf gauge.
Then how you determine how much you want to increase? Like you say 2 mm, is it always standardized 2 mm?
Yeah, the best is, that's why I say it cannot be too thin, otherwise it breaks very easily. So posteriorly, at least you need to have that 1 mm of gap at the back. Yeah, and then the rest is just fill up. So by standardized way, we will say if you have 1 mm of space at your posterior, it will be 2 mm of space at the anterior. So it's usually like, because when our jaw opens like that, right? There's one pivotal point and we open like that. So then your posterior is 1, your anterior will be more than 1. Okay, so when you check that, so when I say 2 mm, I always put it at the anterior, which means that's not much posteriorly that I raise. So it's like a very minimum raise that I actually achieve already.
Okay. Yeah. Then what if
Okay.
like if you don't have scanner, then how you want to take the bite?
Then yeah,
Can I
you have
just
to
use
do the,
because I take like if you take impression of the model, right? Then like
yeah.
you use the wax. Is wax good enough to raise
No.
that amount?
If you
Okay.
want to do a Michigan spleen, you have to take silicone bite. You cannot take normal alginate bite. You better take a silicone bite for precision, because you need the spleen to really sit in properly. Yeah.
Then I still have
So
to ask patient to bite in front like that. Then after that I just flow and then clear everything like that.
yes, yeah,
The
you
anterior
can.
part also flow at the anterior part also.
No, you only need 3 points. So you only need 1 point, 2 point at the most posterior, and 1 point at somewhere around the anterior. So as long as you have 2 stretch of silicone, then you should be able to mount it already. But the problem with silicone bite is because it's also quite bouncy. So you got to trim away the excess silicone so that when you articulate by hand, there's no bounciness to both the models. Then yeah, then you can use silicone. Otherwise, what I do is I will take with Pro-Temp, with temporary crown material. Yeah. So I ask the patient to bite on my applicator, okay, and I know that's where I want it. Then after that, I just load my Pro-Temp material on the left and right side. And because it sets by itself, then after that, when the patient open, then you get 2 pieces of Pro-Temp bite. Yeah, and then just deliver that to the lab.
Oh, okay.
Yeah,
I
actually
think
Pro-Temp bite
that's
is really
better.
good. I really like
That's
it. Yeah.
better because it's rigid.
Yeah, because it's hard. Yes, you're right.
Okay. Yeah, but now I got scanner already, so I think my life is a little bit easier.
And it's not very expensive also, right? Scanner.
Yeah. Okay. Then okay, now that's like getting the bite. What's after the bite? So because you sure you said you send to the lab, then lab definitely will. I mean, do you just should send it to them? Then after the next thing is they give you the splint already, yeah? Or do you still have to check design, because digitally we can do that?
Yeah, usually they will send me a design. There is a few things that I will request, and they usually the lab will know what's my style, like how much is your extension, how far extension you want to go up, how far extension you want to go posteriorly. Usually I have to cover up to the middle part of the second molar. So I will share with you my slide, if you don't mind,
Yes, please.
to show you my. Can you see?
Yep.
Can ya?
Can.
Okay. So anyway, this is what I meant by occlusion points. So if you can see,
Got difference of red and blue color and yellow.
yeah, correct. Okay. So the blue points are usually the points that you want to have. Okay. So if you realize these blue points are for the upper is all at the center part and towards the palatal side. Then the lower is the center towards the buccal side. Okay. So at the very least, you need to have 1 point each. Even if you are delivering crown or like bridges, except the pontic, or implant crowns, if let's say you want to share the load, yeah, or if you're doing composite, just normal composite filling, you want this kind of point. Okay, 1 point each. So you can see this blue line is actually upon excursion. It's on the canine here. Okay, so the red point is still in occlusion. If you can see, it's actually more towards the mesial marginal ridge area. Okay, and then for the lower is all on the buccal part of it. Okay, all on the buccal part of it. So this is still occlusion, but less. Okay, which means if you put in a size 8 micrometer paper, this part, it should be loose. Okay, you should be able to pull out, but heavy on these few parts. Okay, so these are, it's quite important because you need to have contact but not heavy. If you don't have contact and it's open, you usually get patients coming in complaining of cheek butt. Okay, because the cheek collapse and it gets in. So end up you have to build up this one, or you have to build up the buccal side to push the cheek out. So this is how it
Okay.
is. Then the yellow one is even
Wait,
more.
wait.
Yeah. Can understand?
So you have to which one first? You do blue or you do red first?
No, of course, blue is a must. Blue is like each and every of the tooth must have one. Okay,
Yeah.
sometimes you got two will be good lah. If you don't
No,
have
then the
two,
red
at least
color is like your different thickness of the articulating
articulating
paper, or you
paper.
just turn. So which one you do first? Which one you check to get first? You get the blue one or you get the red one first?
Blue is a must. Red is an optional one.
Oh, okay.
Yeah.
So you get
Means
your blue all
red
done first.
red cannot be too heavy, which means if your blue color is at the red color area, then it's not that correct really. Means it's very heavy really. Yeah, means you're like, oh, okay, very heavy on the mesial marginal ridge. So you might have to reduce this one and build this one up so the occlusion now shifts to the
Shift to the
center
blue,
part of
to
the
the
tooth.
center point.
Yeah. Okay,
But
same
if we
goes for
okay,
yellow. Yeah.
okay, yeah. If you then now we're doing just blue, right? You occlude already, right? Sorry if I'm asking something stupid. Then you change to red, right? Because it's heavy occlusion, then you bite, then can still pull out, because it's thinner.
Yeah, usually your articulating paper is this size only one. It's not like one whole strip like that, like how we all use the articulating paper secara panjang like no lah. We usually cut like to the tooth size only. We just ask the patient to bite here, bite here, bite here, bite here like that. So you won't be able to pull out, but you'll be able to tell that there's least resistance here. Here is very
Oh, okay.
heavy resistance.
Yeah.
Yeah. Yeah, and because the articulating paper comes in different thickness as well. So the very thin one, usually you will get here lah, or the blue color dot. Then the blue color dot should be here and here. Then the red color dot should be here. If you want to use that thickness to describe lah. You understand? Okay, or you can just start with red color. So if you start with red color, means this point must have, this point must have.
Okay,
Then you
okay.
change
Yeah.
to something thinner, yeah. Then you will get one here don't have, like that.
Yeah.
Okay, can get
Okay. Yeah,
Yeah.
understood.
Same goes for yellow lah. Yellow is more. So the red color one is 16 microns, or usually I would prefer 16 microns lah. And then the yellow one will be more than that. Means the yellow one should be able to pull out easily. It shouldn't be heavy force on all these yellow color points. Okay, so this is ideal. Of course, not everybody has this kind of ideal type of points right at the center. But if let's say you got a chance to restore the tooth, be with a crown, or you want to do composite onlay or whatever, then you should then consider these points. Okay.
Okay.
So next is how a spleen looks like. Okay, this is a conventional spleen. Okay, and I don't think so you can see that indentation very clearly, but let me just see the next one. Okay, so this is how it is. Okay, very difficult to get 2 points more than that. But usually this is what I do. Okay, 1 point each on the tooth. So this is an upper. Okay, 1 point on each tooth. And then upon excursion, you get this blue color line here. Okay, and then the coverage. So you realize that the patient don't have a tooth here, but he has a tooth on the lower. So I extend the spleen so that there is something to bite on. So this is how it is from a frontal view. Very small, short distance. So in a case where there's a lot of teeth for retention, you can actually just give a spleen this short. Okay, very, very short. Just maybe 2-3 millimeters from the incisor edge. And the retention is very good because you take a silicone impression, so the precision is there. And this very vampire-like fang will be there lah, because this one is where your excursion is gonna take place. So this one I do an upper because I issued the 2 implant crowns for this patient and multiple other crowns here and there. So yeah, I just delivered this. This is a Michigan spleen.
You'll be asking this patient to wear the spleen for how long?
This is forever. Like
Every
there's
night.
nothing. It's like your S6 retainer kind of concept like that.
Every night lah.
Yes. But I review them constantly just to check if there's any wear facet on the spleen. Yeah, then I will polish it, because once it starts to wear off, then you know, like, oh, it's actually it's very heavy at that area. Then you have to then relook at the occlusion. Why is he having so much of force on one side and not so much on the other side? Yeah, and second thing is, if the spleen is rough, then the chances of it having to propagate a crack is also there. So you always want to smoothen it out. So I review my patients with spleen on 6 monthly, like just for scaling, and then after that check the spleen. So you can do that as well.
Technically, you
Case study
shouldn't
is,
have any wearing out of anywhere, right?
It should have wearing, because patients with bruxism, they don't care, they just brux only.
Even if everything is like, already balanced there.
Correct. Already done rehab, but their bruxing habit is still there. So you still get the worn surface on the spleen. So you still have to smoothen it out eventually.
Okay. All right. And
Okay.
means can break also lah. Like mine like that lah, also break ah.
Yeah, there is a possibility it can break, but
Okay.
not so easy lah, like an S6 retainer kind of thin. Yeah. Anything that you use for a long time will break. Even your PFM crown can come out. Your zirconia crown can fracture, This is another case. Also same. There's not much, no teeth here. Also wearing denture at this area. A lot of force on the anterior. So once I adjusted the occlusion, and then I gave her a splint. So now she's very happy with this. Daytime she wears denture. Nighttime she wears this. Okay, and the fitting is also very well. Okay, and this one upon excursion is also canine guided. So there is no you can see there's no canine fang at this area here because her lower teeth is crowded. So basically, I don't need the fang, and this tooth is the one that is in occluding surface, and when it glides, there's already a lot of surface to glide and dislocate and get that disclusion, we call it, okay? So that's the reason. This one is to answer my Instagram punya post. Okay, why it's not on the canine but on the lateral surface. Okay, so this because it has crowding. So sometimes you have to see, not all the case you must be canine to canine. It can be canine to premolar or canine to lateral, or it can be a lateral to a lateral. So it all depends on your design, and when you check in the patient's mouth, these are the few things you should see. So you can see my extension is very low here. Okay, last
Means
time I
you
don't
how
know. Okay,
also
yeah,
sorry.
I put it quite high one. Then after that, I realized patient cannot close the mouth. The lip is like very jutting out. So then I changed to this. Yeah.
Means how also you must do the gliding, the patient must be able to glide.
Yes. Yeah. Because the purpose of giving the splint is so that when the patient is wearing it, the occlusion should be almost ideal. I wouldn't say like perfect, but almost ideal. Then only it is like serve the purpose of you prescribing a splint.
Then for
Okay.
like this, right? Okay, so like this, right? Because you say patient wearing denture, this one if patient is wearing this means you're technically excluding all the teeth, right? It's higher than compared to when the patient is
Yes.
wearing denture.
Yeah. Yeah. Yes.
But it's okay, it doesn't matter.
Yeah, it doesn't matter because this is ideal occlusion. Maybe better than a denture occlusion. Leh. Maybe lah, I don't know.
Okay,
Yeah.
okay, right.
Okay. So
Yeah,
this is
yeah.
another case as well.
Oh wait, then
This
the
one,
fang, the
yeah,
fang, because it can be long, it can be short, How you
yes.
decide long short?
That one, it depends on the design. So when the lab does the design, they will do the articulation. There's a virtual articulator in the design. So they already did the movement in the design already. So from there,
Oh,
you
okay.
can already tell the blue line. So sometimes they have to do it a bit longer because they need to glide so much in order to disclude. Then the fang has to be longer lah.
Longer.
Yeah, some like this case
Okay.
don't need fang because just need enough flat enough surface, and then they already disclude. So then you don't need to put the fang out.
Okay.
Yeah. Okay.
Okay. Yeah.
This is another case. So this case has got multiple bridges, three unit, 6 unit, and then there's no teeth here. So I think this case Jaron knows also. You've seen this patient.
I was just
Then
thinking, macam looks because of the bulu here.
yeah. So this one also he has lower teeth. So I actually added an extra. So this is the fun part about spleen rather than S6. I mean S6 you also can do this where you can just put like a tooth onto the S6, but because this one it's one piece. So you can design to have the replacement of the tooth anyhow you like the extension. So I try to make it as balanced as possible, and also because there's lower teeth. So when I issued the spleen, I actually have this extension. But you will realize this one, I actually not so short anymore. I actually extended it a little bit more because this guy is, the bruxing is, wow, very cao one, okay? So throughout the whole treatment, I think he broke 2 of my spleen already. Yeah. So this one, and also because this part, the whole thing is prosthesis. So I would want to have higher coverage for this case. Okay. Then the last case here, okay, this one is a special case, okay? So I raised the bike, and then anterior is all composite. All of this is composite, root treated and only composite because patient cannot afford crown, okay? And also is wearing denture, okay, to replace the missing teeth. And then you'll realize because the patient has got all composite here, rather than the PFM that you see in the second case, you will realize like my extension is more, okay? Basically, I'm covered everything because if I just do this short, if you imagine, there's a lot of force on these teeth, some more here, no teeth. So then the composite will break lah together with the spleen. Maybe the composite break first before the spleen. So I would rather do this extension. So how do you decide the extension anteriorly? Okay, if it is fully dentate or if there's a lot of teeth, to hold in place, or there's no prosthesis, purely just for occlusion, then you can go it short, like the first case. If there is prosthesis and you want a bit more protection, especially anterior, posterior, all got things one, okay, then you want to extend it more. For this one, pure composite everywhere and full composite here, then I will want a full coverage. Okay, so this is my protocol. I would want a full coverage up to the middle of the 7. If I can, I will try to have bilateral balance. Always never too thin, especially on the occlusal surface. And this 1 mm I'm talking about, starting from the 7, should be 1 mm. And of course, it will get thicker and thicker towards the anterior side lah. Okay, for anterior coverage, okay, full dentate, I already explained. It can be 5 mm or incisor wanted. Okay, extend to the middle third. If let's say you have an anterior prosthesis, like an anterior bridge, anterior crowns, you can extend to the gingival third if you're replacing a lot of teeth and there's a lot of composite in place. Peripheral coverage, so is by default setting. Usually, you can't control this much, and it doesn't matter anyway how much you want to cover on the posterior side, because the whole thing when the patient starts to brush, the stop is actually anterior, okay, and also the thickness you get. All right, you can modify according to the patient's clenching or bruxing habit. I have another patient also, she likes to clench forward. She likes to use her anterior teeth to bite during her sleep. So then you have to issue her a splint that has a little bit of an anterior platform, so she can't bite forward. Now, after she wear the splint, she only can bite backwards. So yeah, you can modify that accordingly. Then check the occlusion. Sometimes when they 3D print, it's not so smooth. There will be some irregularities, and when you test it in the patient's mouth, the points may not be as ideal as you want. So at the time, you can trim according to the first image that I show you, the upper arch and the lower arch. And then after that, you can polish. Remember to polish. Okay, and then you review them. For the first time is 4 weeks. Then after that, you can review them monthly, or like for me, it's 3 monthly, 6 monthly, like that. Okay, that's all. Any questions?
Hello,
Okay.
Aki. Hi.
Oh, someone, yeah.
Hi, Nazrin.
Nazrin.
Oh, hello.
Happy belated birthday.
Thank you. I wanted to ask if
Mm.
like you have a full rehab cases, like a very extensive load being done, for example, for upper and lower processes. So usually you prescribe the splint after you've done all upper and lower processes, or you done half by half. Means that you doing the upper processes and then you do the splint, then you do the lower, or finish all together.
It depends. If the patient's bruxism is very bad, throughout the whole process of my rehab, the patient will have a temporary splint. I will just give her a cheap, soft TAM splint. Okay. Then after I've done everything, I've delivered all my prosthesis, upper and lower, I will convert it into a hard splint, and only for the upper.
Oh, okay. So it will have multiple splint prescribed to the patient, is it?
Yes, yes, throughout the whole process. But it's not the hard one. It's just a soft, chewy type of night guard that I will just prescribe just for the patient to protect, at least at night, throughout the whole rehab procedure that I'm doing. Until I finish everything, then only I prescribe the hard splint.
What's your take on bilamina splint?
Yeah, I quite like to do that, especially for edentulous cases. Like just now, 1 or 2 of those cases are bilaminar spleen. So it's still hard on the outside and it's slightly soft on the inner surface. So it's easier to adapt to the patient's tissue in cases where you have multiple missing teeth and you want to prescribe a spleen, like just now's that case like that. So those are bilaminar spleen. Yeah, bilaminar spleen done in the lab is actually quite easy. After they've printed, the whole thing is actually still soft. They just do a sugar coating on the outside to make the outside hard. That's it. So that's how the process is for bilaminar spleen.
So is it make I don't know, based on my thinking lah, I think that if like bilamina, because we didn't prescribe like acid because it's too soft. So when patient have bruxism, clenching, it will cause the acid to wear faster, right? That's why we prescribe Michigan splint, which is hard. So when we have a bilamina, which is we have the goods from the both sides, so why wouldn't we choose bilamina for all cases, or we need to choose Michigan?
It's still best to have Michigan. Bilaminar spleen, there is still a tendency of movement of the spleen when the patient is bruxing. You have to imagine the patient is unconscious, like not really unconscious, subconsciously moving, having a lot of heavy jaw movement that can break their teeth. So bilaminar spleen is still soft on the inside. When the patient does that movement, there's still a little bit of moving. So you want something that fits in and not move. And after that, let the lower brux away the spleen that they have. So for me, it's always 100% hard spleen at the end of the rehab. But in between, like for example, you want to give a bilaminar spleen, that's fine. I wouldn't want to give a spleen that really needs to spend a lot of time adjusting the occlusion when the whole rehab is not done yet. So I just give them something that's soft and just you wear this first. Yeah, then at the end, then only I betul-betul give the hard spleen that fits in. But then sometimes like in cases where there's edentulous spaces a lot, then yeah, a bilaminar spleen is their final lah. Okay.
Last question. Would it be a detrimental effect if you're using hard material with the prosthesis itself? I mean, like, because the Michigan is hard, so your prosthesis, for example, the veneers or the crowns you also hard, will it be like cause something fracture of the
Yes.
prosthesis itself?
Correct. It's true. But the resin that we use to print, the strength is less than zirconia, and of course, it's less than metal. So if you're talking about having full mouth rehab cases on upper and lower, and you deliver an upper spleen, you are worried about the lower prosthesis grinding on the spleen, right? So then the lower posterior shouldn't be a problem against the resin. But for the lower anterior, if you prescribe a veneer, then you should have relieved the occlusion. Means even though the patient is doing the forward and backward bruxing, there is not much of contact. I wouldn't say zero contact, but very light contact, or even a lot of relief done on the back part of the spleen so that nothing touches it. So it's just bruxing on the posterior side.
So you still have to let patient to got space, meaning
Yeah,
patient will still
always
move
will have
back.
space. Yeah. You
Mm.
cannot lock the jaw. You can't do long enough that the patient just like there and the jaw cannot move. You
Yeah.
can't do that. Yeah. Eventually the patient will still do the movement lah. Yeah, it's just how you want to train the movement with that spleen that you give.
Oh, so it's like within the boundary lah, where where within the
Yeah.
area that patient is bruxing.
Mm-hmm.
Okay. Yeah, let's
Okay, I hope I asked you a question, yeah, Nazri.
Can we just see
Yes.
the picture
Thank
of the
you.
bilaminar spleen again? If you don't mind going back to your...
Yeah.
She got a bilaminar spleen.
Just now she had more.
Yeah. This
Because
one is a bilaminar spleen.
Oh.
This is
this
is a yeah.
And then you put all the the tooth, right? All those missing tooth area, then you add the tooth there, right? Then
This one,
yeah. Then all these areas, right, will it be touching onto the gum, like pressing onto the gum?
it is got lah, the likely lah. That's why I have to take the impression with silicone so it's accurate.
Cannot just
Not
scan.
heavy.
you scan
Can scan. Yeah, I scan
can
lah. Yeah,
okay.
scan. Yeah.
Understood.
Okay.
Nice.
It's better, right? Better than sitting on the gums, right? Instead of just hanging there. You don't want to leave a space there because then later you will flex like that.
Yeah. So it's just very light contact on the tissue surface.
Okay.
Okay.
Yeah. So I think we passed our time.
Again.
Nothing to talk about. Also can talk about. Also took quite long. Yeah. So if there's no other questions, then maybe we can just conclude for tonight.
Yeah.
Can we take a picture with everyone if possible?
Oh.
Oh. Yeah,
Just
if you
I
want to.
remembered.
If everyone don't mind, can just on their video camera
If you guys don't mind,
They
what
start to leave already.
before
They
you
were like,
leave.
okay, that's really
tadi ke Nazrin?
Yeah, anyway, yeah. You can take like that also. Can I can just take
Yeah.
whenever you can. You take yeah.
Yep.
Yeah. So thank you everyone for joining us on our Buka Mulut session for number 2. Hi Sharon, thanks for showing your
Thanks for
face.
joining.
Yeah. Though do check us out. GDPA where is our Instagram link here.
I
Not
will
here,
add
but
it. I will add
you
it
can
right
you
now.
can find us on Instagram and all, and stay tuned to our next session. So far, we're doing it once a month. So last month was our first session. This month is our second session. We still have another 2 more to go. What are we going to speak about next month?
Next month we got Dr. Ian
Oh,
Fu
yeah,
from
Ian Fu.
Smile Bay.
Yeah.
That one is
Yeah.
talk about smile design. That one is more of his forte lah.
Yep,
Mm.
yep. We're talking about smile design. He was with us last year also speaking about smile design. So this time we're just gonna chit chat, and if you all got
Yeah.
more questions, why not? Yeah, just very casual. Look at where we are now. So yeah, hope you enjoy it. Thank you for joining us. Thank you for spending your time with us too. And see you all next month.
Bye everyone.
Bye guys. See you,
Thank
Nazrin. Bye.
Bye bye. Hey, so coming back to that thing, so the Lego plan, how? Okay, I want to go.
Thanks for joining. Huh?
Yeah,
What do you
Hey,
want to
stop
say?
recording. Stop
No, you have to stop
recording.
recording first.
Okay.